I welcome Dr. E.K. Abdul Nasser, President ISA Kerala State Chapter, to start today's proceedings. Welcome, Nasser sir.
Good evening, respected senior teachers, ISA National President-elect Dr. Venkatagiri. After the last 2 weeks exhaustive discussions in the PG refresher course, once again we are back to our PG update program. This time it is important that the theory results is already out and people are waiting for the practical and viva examination. In today's topic, we have two eminent faculties, Dr. Deepak K. Tambe, who is the retired Professor of Excellence, Department of Anesthesiology and Intensive Care, GB Pant Institute of Postgraduate Medical Education and Research Center. He is the former Dean of Maulana Azad Medical College, New Delhi, a senior teacher and an excellent academician who is talking us on transesophageal echocardiography in anesthesia practice. This is a topic which is relevant in the newer developments because more centers are coming with well-equipped situations and we must be familiar with this. So on behalf of ISA Kerala State Chapter, and I am really honored to welcome you to this today's PG update. Your presence definitely will make a difference in our academic program. Welcome you, sir.
Thank you.
The second topic is on basic principles of ultrasound for postgraduates, a topic which is a must that it is very difficult to survive without ultrasound and without a basic knowledge of ultrasound because it is finding its application in all fields, in our nerve blocks, in central lines, and now few people may be moving on to the pain, and this becomes an inevitable part. And essential knowledge on this topic is a must for our practice of anesthesiology for the future. We have our own active member and a faculty who is a consultant anesthesiologist at Aster Medicity Cochin, Dr. Jitendra T, an eminent teacher, an eminent academician, and a person who is well known in the field of regional anesthesia. Sir, on behalf of ISA Kerala State Chapter, I welcome you to this meeting.
Thank you, sir.
I take this opportunity to welcome our President-elect ISA National, who is always with us, guiding us and helping us to form all the framework of all the activities, Dr. Venkatagiri. Dr. Venkatagiri, I am honored to welcome you to this meeting. I also welcome our webinar coordinators who is spending a lot of time with us, always present with us, always controlling the academic activity, Dr. Rajesh MC, who is the scientific chairman of ISA Kerala State Chapter, and Dr. Vijesh Venugopal, who is the governing council member of ISA Kerala State Chapter and professor of KMCT Medical College, Kozhikode. Welcome, Dr. Rajesh and Dr. Vijesh.
Thank you, sir.
There are many senior teachers with us who is always encouraging us to organize this thing. I am not mentioning their names, but on behalf of ISA, I welcome all the senior teachers who are with us. I take this opportunity to welcome our vibrant secretary, Dr. Benil Isaac Matthew, who is taking a lot of pain in organizing such wonderful programs for the postgraduates. I welcome all the delegates, all the teachers, all the senior officials once again on my own personal behalf and on behalf of ISA Kerala State Chapter, and request Dr. Venkatagiri for few opening remarks. Dr.
Good evening, President Nasser, Secretary Binil, today's faculties, Dr. Tempesar and Dr. Jitendra, coordinators Dr. Vijesh and Rajesh. Good evening all. We have galaxy of inspectors which includes senior past president Dr. Agnihotri is there, Dr. Kameshwar is there. There are many HODs including Dr. Pradhan from Orissa, SGK Murthy from Andhra, and many more. And that shows that the popularity of the program and people from all over India attending this program. Many I am not able to identify because they have not logged in with their name. So able to identify only people or seniors who have logged with their name. And we are fortunate that Dr. Deepak Tempe has agreed to give a talk on that. A great personality who has contributed a chapter in Miller's book of anesthesia and has 6 books of his own and a book on transesophageal echocardiography. So we are hearing from the horse's mouth today, and we should be lucky to hear from him. So I wish that everybody will enjoy this talk and get benefit from it. Thank you both Tempe sir and our own member. Thank you very much.
Thank you, Dr. Giri. I request the webinar coordinators to initiate the academics program.
Yeah. Good evening, everyone. We'll start off with the first topic, that is basics of ultrasound for postgraduates by Dr. Jitendra. And Dr. Jitendra was already introduced. He's the consultant anesthesiologist and intensivist at Aster Medicity, Cochin. Welcome, Jitendra, and over to your talk.
Thank you. Just start off the slides. Yeah. Is it clear there?
No, not yet.
Not yet, come. One second. Is it opening there now?
Yeah, it's coming. I think you have to open the PPT. Yeah. You go to full screen, right? Yes, Jitendra, it's clear.
Yeah, okay. I'm trying to just take off all those things from the screen. I'm not able to see properly. Yeah, good evening, everyone. I'll just go through some of the basic principles of ultrasonogram. I thought of dividing it into two. So one regarding ultrasound classes. One is the basic principles. Then we'll have next session, probably after a few days, we'll have the second one, that's basic applications of ultrasound in anesthesia and critical care. So I'm just going to just brush around some of the basic things, what you need to know about the ultrasound, how to optimize the images, what are the settings which you need to do, and how to identify structures, its echogenicity, etc. So why is actually ultrasound physics important for us is we need to know the knowledge, we need to have the knowledge of ultrasound physics needed for image optimization. The first thing which we need to know, need to identify the appropriate transducers. You need to identify the gain settings, depth settings, and also learn about the tissue echo characteristics, which will come through the next few slides. And the objectives of this lecture would be mainly explain the ultrasound wave creation, choose appropriate transducers, describe factors that affect the ultrasound image, discuss image optimization techniques, review applications of specific imaging modes, and something about ergonomics. Now let's see what's actually ultrasound. So the frequency of the sound waves used in ultrasonography is well above the limit of human ear, which is about 20,000 kilohertz. So for medical ultrasound, what we regularly use is a frequency which ranges from 2 to 15 megahertz. There are some probes which actually go beyond 15 megahertz, so the resolution gets much better. So as we know, the use of high frequency waves is used to generate an image. So sound waves can be again described by the frequency, wavelength, and velocity. So let's see what is frequency. It's the number of cycles or waves that are completed every second, and the wavelength is distance needed to complete. Now let's explain about the propagation of ultrasound by the theory of acoustics. So you know when a sound wave is being emitted from a transducer, that moves like a wave-like fashion by expansion and compression of the medium or tissues through which it travels. So we know that ultrasound travels at different speeds depending upon each material. So bone, tissue, the fluid, etc., have different speed transmission of ultrasound waves through those mediums. So what we see here is ultrasound actually uses sound waves to be emitted from a transducer. It goes to a tissue, part of it returns back, and then we get an image through the monitor. So while they pass through tissue, they're either reflected, deflected, or either absorbed in the body. So the reflected waves which comes back to the transducer actually produces ultrasound image. So the more the sound waves are reflected from the transducer, the more hyperechogenic, that is whiter, is a tissue imaging. With the reduced reflection, what happens, the image will be more hypoechogenic or anechogenic if there is no reflection, which is termed as a black image. Now we need to know both the speed of sound through the tissue and tissue density impact and the quality of the ultrasound image. So as we said earlier, high density tissue generally generates multiple echo reflections. Example like what you see through the bone or calcareous structures, which produce actually hyperechogenic images. We'll see the slides later on that. And fluid actually reflects no sound waves. It actually allows the sound waves to pass through it to the structures which is posterior to it. So therefore, it looks like an anechoic or black tissue. And soft tissue, example organs, somewhere between the hyperechogenic or anechogenic. So what do you say about isoechogenic? When you say about isoechogenic, it's when the tissue has the same echogenicity as the surrounding tissues. So as I told you earlier, the bone, the sound being transmitted actually through the bone is 4,080 millimeters per second. Tissue is 1,540 meters per second. Through the gas is 330 millimeters per second. Now we need to remember that speed of sound is dependent upon the medium through which it is traveling. And since the ultrasound machine is calibrated to display returning echo moving at a speed of 1540 meters per second, echoes reflected by bone or gas will not display in the same way. So an artifact will always result from those returning echoes. Now this is what I mean by high echogenicity. What you see on the left extreme is hyperechoic, where the structures will be seen bright like this. Next is isoechogenic, which comes in between the anechoic and hyperechoic. And hypoechoic is actually, in comparison to anechoic, what you see, it's a lighter image over there. And this is anechoic, means it's actually, there is no sound, sound waves which is reflected from that structure. So that is what you see when you go through, when you image through a vascular structure. Now that is the first one on the left side is hypoechoic, which has got a less echogenicity compared to the surrounding tissue. This is a structure over there which is hypoechoic. Now, when you say about hyperechoic, it is more echogenic than the surrounding tissues. So it looks more brighter. Now, when you say about anechoic, there is absence of echoes. So there is actually the sound waves is completely transmitted through the fluid structure over there, goes posteriorly, and what you see is a reflection from the posterior structure. So this looks totally black and look anechoic, usually seen with cysts or blood vessels. Now, isoechoic, what you see in the next picture is basically the echogenicity of this tissue with the surrounding tissue is the same. So it's said as isoechoic. Now, what do ultrasound machines actually do? It converts energy. So what happens? There's an electrical energy which comes to the transducer, piezoelectric crystals. There's mechanical. There's a mechanical waves which are set in. The ultrasound waves are set in, which goes through tissues and is being reflected back to the transducer. It's again converted back to electrical energy and goes into the monitor to analyze and create an image. So this is basically a transducer, which is what you see. There's a power supply coming to the transducer, and there is a matching layer over here, beneath which you have a piezoelectric crystals, which are actually stimulated and then sound waves are produced. Behind that, you have this is the acoustic insulator. So there's a backing material behind the piezoelectric crystals. There's an alternating current which comes over here, stimulates all the piezoelectric crystals, and sound waves are produced from the foot end of the probe, which is in contact with the tissue. Now the same thing is the transducer anatomy. What you see, there's a backing material, and this is the covering of the probe, the footprint of the probe, and you have the crystals arranged over here just beneath the backing material, and between the backing material and the layer, there's a matching material which actually augments the sound waves. Now, how's ultrasound generated? So you know that ultrasound has got a piezoelectric crystal. The probe has got a piezoelectric crystals. So ultrasound is actually generated by the piezoelectric crystal stimulation. So when electric field is applied, crystal rings like a bell at a resonant frequency, determined mainly by its thickness. Same or similar crystal is used as a receiver to produce an electrical signal when struck by the returning wave. So same piezoelectric crystals or the probe is used for emitting the sound waves as well as receiving the sound waves. And how is the image produced? So an electric current which is passing through the cable to a transducer, as you see in the image, is applied to crystals, causing them to deform and vibrate. This vibration of the piezoelectric crystals produces ultrasound beam. The frequency of the ultrasound waves produced is predetermined by the crystals in the transducer. So you have transducers of different frequencies. So it's not a continuous waves which are produced, but it is produced in pulses. So because the same crystals are used to generate and receive sound waves, and they cannot do both at the same time. So once it emits, then it has to come back. The sound waves have to come back to the transducer, and the piezoelectric crystals have to be stimulated, and then impulses sent. The electrical signals sent to the monitor. So ultrasound beam enters the patient, is reflected back to a transducer, and reflected sound waves cause crystals in the transducer to deform again, produce an electrical signal that is converted to image and displayed on the monitor. So what you see normally is like transducer generally emits only ultrasound by only 1% of total time. The rest of the time is spent in receiving the echoes. Now there's something called, it's all there on the machine. When you switch on the machine, you'll find the pulse repetition frequency. You need to know about the pulse repetition frequency also. I'm just going through the basic theory. Then we'll see some images later on. So relatively slow speed of ultrasound in tissue limits the rate at which ultrasound information can be acquired. So you need to actually wait for each pulse to fade away before the second transmission. So what happens if the second pulse comes too early? The last returning impulse from the first pulse will overlap with the first returning impulse from the second pulse, and you will not get a good image. Now, pulse repetition frequency is set in order to allow time for the most distant echoes to return before sending the next signal, next impulse. So pulse repetition frequency will be slower if trying to image a larger area or trying to grayscale and Doppler at the same time. And reducing scan area can help increase the pulse repetition frequency. Example, if you're trying to image fast-moving structures. So you need to know something about the imaging modes. So different machines will have, you'll have the modes and different, settings are different for each machine. So basics, two modes which you need to know for the basic anesthetist for the ultrasound is, like, see, all these images are produced in the two-dimensional mode. So not a three-dimensional, it's a two-dimensional mode. So you have two modes which are routinely used. That is a B mode, which is a brightness mode, or M mode, which is a motion mode, which is commonly used for echo for value to transvisual transthoracic echoes. So in B mode, what happens is echoes are represented by dots on a line that forms the base of two-dimensional image. So when you do a real-time B mode ultrasonography, it allows a complete two-dimensional cross-sectional image to be generated by multiple B-line modes. And in real-time B mode, the transducer sweeps ultrasound through the patient many times a second. And with each pass of ultrasound beam, multiple lines of dots are generated on the monitor, producing a complete image. So these B mode lines remain on the monitor until the next sweep of the ultrasound beam. And because several sweeps are produced per second, in moving or changing real-time images generated. This is a basic method of how a real-time image is created by an ultrasound machine. Now, M mode or motion mode is usually used in echocardiography. I think Deepak is going to elaborate on that. And it allows the sonographer to measure the heart to assess the cardiac function and the chamber size. M mode again uses a single B mode line with the amplitude of echoes indicated by the brightness of displayed dots. And the difference is that information obtained from the single line is constantly swept across the monitor. So the motion of the body parts being investigated is displayed along the horizontal axis. Now we need to know something about the color Doppler and the power Doppler. Okay. So the color Doppler actually displays the velocity of the moving blood. It is a qualitative rather than a quantitative angle. It's qualitative and it's angle dependent. So it indicates the presence of flow as well as direction of the flow of the blood. So power Doppler. So let's see what is power Doppler. Power Doppler actually basically displays amplitude of signals, and we'll see one video on that. Displays amplitude of signal or how much color is displayed, but does not show the direction of the flow and is less angle dependent. So there's something called Doppler shift as well as Doppler angle. What you see here is like you see the blood flowing from the right to the left, and you see the transducer over the tissue. So sound reflections of moving objects actually undergoes frequency changes. So as it moves from this place to here, from this side, and when the sound waves come over here, and it's being reflected on the RBCs, which is being struck by the sound waves, and the frequency which returns is different. So there's a difference between the emitted and received frequency, which is measured, and this is called the Doppler shift or frequency shift. So now the Doppler shift and Doppler angle are then calculated, allowing determination of blood circulation patterns. We'll see an image video on that after this. Again, in color Doppler, I told you frequency changes are converted into color on the screen. So when you see blue color, that means the blood is moving away from the transducer. This is blue color shows blood moving away from the transducer, whereas red color shows actually blood moving towards the transducer. So what you see here is blood moving towards the transducer shows red, whereas the blood moving away from the transducer will be seen as, what you see here will be seen as blue. So there is something called as positive Doppler shift and negative Doppler shift. This is all a little bit confusing, but I think when you do it practically on the patient with the machine, you'll be learning more of these things. So what do you mean by positive Doppler shift? When blood moves towards the transducer, what you see here, the wavelength of the sound wave shortens. See what you see there is the wavelength is shortened, and sound frequency increases. Okay, so but when you go for a negative Doppler effect, it's different. The frequency decreases as well as the wavelength increases. This is what is called as positive Doppler shift and negative Doppler shift. Now, as I told you, the imaging modes, when you see the color Doppler, the pixels are arranged, pixels are aligned color based on the mean velocity of the blood flow and displays the direction of blood flow. So this, what you see blue is away from the probe, and what comes towards that is the red. This is the abdominal aorta, and here what you see is the bifurcation. This is power Doppler, which shows that speed of blood cells displayed on a time velocity graph. Velocities may be measured quantitatively. This is a carotid Doppler which is seen. So this is across a time, and this is a velocity. What you see here is the velocity, and the x-axis is time. I'll just put a video on that. See what you see here when you put the color Doppler, this is basically ultrasound of the neck. What you see here is the carotid, and this is the internal jugular vein. So when the blood flows, when you see initially, when the blood flows towards the probe, you see as red, what I told you earlier, and what blood which flows away from the probe, you see is this blue. So when you angulate or tilt the probe, the color changes. See what you see there is the carotid shows blue because the blood flows away from the probe when you tilt the probe, and the blood from the IJV flows towards the probe, that is shown as blue. So when you see some structure like red or blue, it doesn't mean that red is always artery and blue is always vein. It depends upon how you angulate the probe or tilt the probe. Now when you look for the power Doppler, okay, there's a Doppler which is put over the carotid. So you can see the pulsatility of the vessels. That is also one way of identifying the structures. So if you look at this image, it shows like a negative Doppler shift, but basically because the image is inverted, I'm just dropping down the baseline. So what you see there is a pulsatile flow of the artery. So you have the time as well as velocity being plotted. There's the carotid pulsations. It's again the carotid pulsation. Just put this volume, increase the volume for you to just appreciate. So that's how you identify a vessel on an ultrasound. Sorry, one second. So when ultrasound passes through tissue, what all are the things which happens? So first thing is like you have an attenuation. Attenuation, which basically means that the ultrasound beam weakens as it passes through tissue, and it can be caused by these factors. One is reflection, that is the ultrasound beam which goes towards the tissue is reflected back to the transducer. Then second thing is scatters. It scatters in multiple directions. Then it can get refracted that is redirection of bending, and the tissue can absorb the ultrasound beams and it can be converted to heat. So all these factors determine what is the echogenicity of the material which you scan. So the same thing, what you see in the picture on the left upper part is like you have the reflection. The ultrasound beam passes through medium, first medium, and the second medium. Part of it is reflected from the tissue and part of it is transmitted through the tissue. The second one, what you find is a deflection of the ultrasound beam, which actually hits on a target, and then it is deflected from the tissue. The third one is actually absorption. Part of the ultrasound beam which goes through the tissue gets absorbed and converts into heat energy. The last one, what you see there is scattering of the ultrasound beam. Now it can be linear beam fire or a multi-beam fire. The initial ultrasound machines always all had a linear beam fire where there's a parallel, what you see there is like parallel beams of ultrasound waves going down and it gets reflected back. Now with to increase the clarity of the picture and clarity of the image what we get, there's a multi-beam firing or multi-beam enhancement which is incorporated into many of the ultrasound machines. So that improves the quality of the ultrasound and images what is being created. So that is actually by sending the pulse in multiple angles. So you get more information, artifacts are reduced and increased edge detail is obtained. So most of the machines now come with a multi-beam enhancement. And that's again used for needling while you do needling for a nerve block. Now these are the common transducers what is routinely used in your clinical practice. What you find there on the left is a linear probe that's called the high frequency linear probe. You have the curvilinear probe and the last one is phase gyro probe. So linear probes are basically used to scan the structures in the superficial area, which is actually, you get a better image when you scan structures from 0 to 4 centimeters. So beyond 4 centimeters, the linear probes are not that effective. So we'll come to the reason why it's not effective. And for curvilinear probes are usually having a lower resolution, but it's got a better penetration. So linear probes have got a higher resolution, a lower penetration, and is a high frequency probe. Curvilinear probes are lower frequency, better penetration, lesser resolution. And phase gyro probe is commonly used for echo of the using for echo and as well as for scanning the thoracic cavity and abdomen. So this is a pediatric probe where this is the footprint of the ultrasound probe. So what you see here, the footprint is quite small enough. So for pediatric cannulations or pediatric blocks or any other pediatric procedures where you need to use ultrasound probe, this is a probe what is used. It's called a hockey stick probe. There are many other, this is one of the manufacturer's probe. There are many other probes which got a small footprint which is used for the pediatric purpose. So same thing what I showed you earlier, there's a low frequency probe, this high frequency probe. So low frequency probe has got an ultrasound which has got a long wavelength like this and a spatial wavelength of 3 cycles, whereas for the high frequency probe, the wavelength is short. You have a higher amplitude of the ultrasound waves for the low frequency, whereas it's a lower amplitude for the high frequency probe. Now, how do you identify the transducer in all the probes? So linear probe is commonly formatted as L. The footprint is from somewhere between 25 to 38 millimeters. The pediatric probe has something around 25 millimeters of footprint, whereas the frequency ranges from 6 to 13, and there are some transducers which goes even higher on that, above 15. A curvilinear probe is usually formatted as C, and the footprint is around 60 millimeters, what you've seen, that curved probe, and the frequency is 2 to 5 megahertz. And phase gyro probes, again, the footprint ranges from 90 to 21 millimeters, and the frequency which is being used in the phase gyro probe is between 1 to 5 megahertz. Now, what is the anatomy of the ultrasound beam? Sound wave is focused into thin slice. It's approximately the thickness of a credit card. So you get a 2D tomographic slice. What you see there is very thin thickness. It's like what I told you about it's a credit card size. So image what you see, and it's a very thin slice. So you need to understand that you're just seeing a 2-dimensional thin slice. So when you see structures, you have to identify it properly. That's what I said is 1 millimeter thickness. Now, before starting off with the ultrasonography for any procedures, you need to know something about the knobology. The first and foremost thing what you need to know was switching on the ultrasound probe with the power button. Next is you have to identify, check out the frequency or you need to select the probe, what is being to be used, like what I said, like superficial structures, you need to go for linear probe for better resolution. Deeper structures, if you identify, you have to go for curvilinear probe. And for echo, you need to use the phase stereo probe. So then you select for the mode of scanning, that's either it's a 2D mode, either you select for the B mode or M mode, depending upon what you're going to, what you want to identify. So M mode is again used for, it's a motion mode. And parts to examine, you have to select either nerve, vascular, musculoskeletal, or small parts. And depending upon the depth of the structure, what you need to visualize, you need to adjust the depth on the machine. I'll show you the settings on the machine. And the gain. So gain is, you have two gain adjustments on every machine. Either it's an auto gain, then you have a manual gain, and so something called TGC is a time gain compensation. And then again, if you want to see the vascular structures, you want to see the flow, the velocity, you can use a power Doppler as well as a color Doppler. So these are two machines which has got the basic button, basic knobs on it. So power button. So first, this is totally different. This has just got a far gain, near gain, far gain, and total gain, and there's an auto gain. But this machine has got a time gain compensation where you can actually adjust the gain at each level using these knobs. I'll just switch on the video for you. Once you switch on the machine, you need to first identify which probe you're going to use. So you need to connect the probe first. Some of the machines have multiple probes connected to the machine, and you just need to select the probes. Here we have actually connected the linear probe onto it. So that shows high frequency linear probe, and the study is nerve. And what you see on the right side is the depth at which the probe is set, the image is set. Next, you can adjust the depth based upon whether the patient is thin or obese patient. Once you set the thing, you can actually go for auto gain, where the machine itself sets the gain. Gain is nothing but it's a brightness, but it's like the ultrasound waves which goes down is reflected back. So you can amplify the ultrasound waves which actually go to the tissue and gets reflected. So you select which type of scanning what you want to do, whether it's a nerve, muscle, or a soft tissue part. Now you select the mode, that's a 2D mode, where you're going to see with the linear probe. These are the basic adjustments which you need to learn before you start an ultrasound spout scan or a procedure. So that's for the near gain adjustment. Basically just the amplification of the sound waves which comes back to the transducer. So that's where you actually increase again, the screen looks like it's too bright. So you need to actually optimize the gain to see the structures in a better way. Now you need to know something about the depth and frequency, the relationship between the depth and frequency. So these two are actually related to each other. So lower frequency needed to image deeper structures, like what I said earlier, and higher frequency actually limit the image depth. So higher frequency produce better image quality and better resolutions. So identify those structures. And then one more thing which you need to know about is the effect of frequency on depth. Here, what you see that the frequency what is seen on the right side is 2 megahertz. The frequency what is seen here on the left side is 5 megahertz. So as you reduce the frequency, as you see that 2 megahertz, the frequency is low, the structures, it penetrates much better, and you see the structures in the posterior aspect or the lower part of the screen much clearer than compared to the on the left side. Now there's something due to effects of depth on attenuation. So attenuation is nothing but this weakening of the or dampening of the ultrasound beam or sound waves which comes from the posterior aspect or deeper aspects of the tissues. So what you see in the left side of the screen, you can't see any structures beneath that. So that means the beam is weak from here. What is being reflected from here is weak. You're not getting an image. So what you do is like you need to compensate that. How do you compensate that? Some of the machines have an auto gain compensation, or something. Some have a time gain compensation, which you can do manually. So this is a machine which is called Aloka, which has got a time gain compensation where you can actually adjust each of the settings and adjust the gain at each level of the tissue. So I'll just show you that image how we do. This is general. The knob which is being used now is a general adjustment of the gain. And here you can individually adjust the gain at each level. So what you see here, as I move the knobs to the right side, the gain increases and it becomes more and more bright. So you need to learn to optimize the gain for the imaging of the structures for any procedure. So as I increase the gain, you can see the color, the brightness being changed at different levels. So if you want to see a structure in the middle of the screen over here, you just need to amplify the sound waves which comes from here, or increase the time gain compensation at this level, what you see here. Now we need to set the depth also again. Next setting, what you need to learn about is adjusting the depth for structures which you need to visualize. Depth should always be set 1 centimeter below the targeted structure. So what you see in the first image here is that it's too shallow. I'm trying to see the vascular structure over here, which is the internal jugular vein and the carotid. But the depth set here is around 2.2. So I need to increase it. So what I do next is I increase the depth. So what here in the second image, what you see is the depth is around 6 centimeters, where you're seeing a lot of unwanted structures beneath the probe. So what you want to see here is at almost 2 to 3 centimeter depth. So this is not indicated. So what you do is that you have to reduce the depth. So this next image, what you see, it's too deep. And the last image, what you see is just right, where you want to see the structures in the middle of the screen at the center. This is around 2 centimeters. So the depth is just again at 4 centimeters. So identify the structure, keep the structure in the middle of the screen, and adjust the depth so that you just optimize the image, what you have to see. So if you want to see a structure which is important, like a lung or vessel beneath the structure which you're targeting, then you have to the depth should be adjusted accordingly to produce a good view of the field and improve safety. Just like what you do for go for a supraclavicular block, where you want to see the lung, the apical part of the lung, which is beneath the plexus. So if you don't see that, if a needle bypass and goes and hits the pleura, you're going to be in trouble. So identify those structures also. So keep that structure in the image view. Now again, echo brightness is nothing but gain. So you need to choose the best gain settings. So what you see on the left side is a too little gain, where actually the image is not, the sound waves are not well amplified to identify the structures. So what you see on the right side, this middle part is actually too much of gain, where the gain is increased, the amplitude of sound waves, which returns from the tissues, is amplified, and you get a more brighter structure, which is not the ideal one. So what you see in the right extreme is a just right adjustment of the gain. So gain is nothing but increasing the brightness, which is actually increasing the amplitude of sound waves, which comes from the structures. Now we need to know about the probe orientation before you start an ultrasound imaging or a procedure. So how do you identify the probe orientation? So what you see, most of the probes will have a prominent notch on the side of the probe, which corresponds to the blue dot over here on the screen. So some may have that notch, or some may have just a ridge over there. So what you see on the left side of the screen corresponds to the notch. Okay. This is how you identify the structures. I mean the probe, orientation of the probe. So you can put some jelly on the probe, touch on the one side of the probe, and when you touch, you see that this side corresponds to the blue dot on the screen. So based on the position you keep the probe on the patient, you can identify either as the left side is medial, right side lateral, or left side is cranial, or right side is caudal. Okay, this is how you identify the orientation of the probe. Now, once you keep the probe on the patient, you can manipulate the probe in 4 ways. That is, a mnemonic is something called PART. That is pressure, alignment, rotation, and tilt. So why do you use pressure with the probe on the tissue is basically to reduce the depth of the tissue beneath the structure to be targeted and the probe. So you get a better visualization. Suppose your tissue, the target which you need to see is around the depth of 6 centimeter. There's a little bit of 2 to 3 centimeter thickness of fat. You can actually use a little pressure with the probe on the skin, and then the depth is reduced, and the structure which needs to be targeted comes a little more higher up and comes into the view between 0 to 4 centimeter, and you get a better image quality. Second is alignment. The third is rotation. Alignment is basically sliding the probe up and down or cranial and caudal to identify the structures. The third part is called rotation, where you can actually rotate the probe clockwise or anti-clockwise and actually get a short axis view of the structures or a long axis view of structures, where you actually look for the vascular structures, or even nerves can be looked at in the short axis and long axis. The last part is again tilt. Tilt is basically tilting the probe cranially or caudally and getting a different angle of ultrasound beam which goes in and reflects from the structures which needs to identify. And then you need to actually, you can see structures at when you add, when you tilt the probe, you see structures at different depths. So you need to know that when you tilt the probe, the depth increases of the tissue, the structure, what you need to identify, the depth is little more. Now this is again sliding and tilting. So when you actually slide, so what you do is, what you see here is a sliding technique where the probe is kept and I'm trying to identify the C6 and C7 intervertebral space. And as you slide down, what you see there is you see the C7 vertebral process and the transverse process, etc. So that is one technique. And then when you actually use the ultrasound probe, tilting of the ultrasound probe, what you find, the ultrasound beam actually, which was directed initially to C6, is directed to C7. So that is one way of identifying the structures from cranial to caudal also. Now, this is again something which you need to know. When you tilt the transducer probe, when you go for an out of plane technique of needling, when you tilt the ultrasound probe, you can actually see that the needle actually may cross the ultrasound beam, and the target may be over here. You may not see the tip of the needle, so which is a little bit problematic when you go for an out of plane technique for a needling for the nerve blocks or vascular access. So when you tilt the probe, you need to actually tilt the probe to see the tip of the needle. So here you don't see the full length of needle, you just see the cross-section view of the needle. So it's a little bit difficult to do for a beginner. So you need to learn to do in-plane technique. So these are needling techniques what you routinely use. This is an in-plane technique which comes from the lateral part of the probe to the medial side, or from the medial to lateral side. And what you see is that you can see the full length of the needle when you go for an in-plane technique. Whereas this is a footprint, actually, what I told you earlier. When you go for out of plane technique, what you see is like basically you just see a cross-sectional view of the needle. So when you see a cross-sectional image of the needle, that doesn't mean that it's the needle tip. It may have actually crossed the ultrasound beam, which is actually cutting the needle, and the needle tip may be beyond that ultrasound beam, what you see. So that is when you may have to tilt the probe a little bit and try to identify the needle. Now, when you go for ultrasound imaging, there are some usual artifacts which are seen, which are actually untrue images that does not exist in reality. Some of the artifacts which routinely what you find, there's a reverberation artifact, the mirror image, or the acoustic enhancement artifacts. So some of the artifacts which can help confirm such things are lung, bowel, or free air, which shows a dirty shadow. Gallstones show acoustic shadowing, and cyst shows an enhancement. We'll just see the images like that. See, what you see here on the top is artifact caused by the ribs or sternum. Okay. What you see below that is the artifact caused by the bowel, which is just underneath the abdominal wall. So this is the artifact caused by the bowel. So you don't see any acoustic window beyond that. So again, when you see here, the rib is over here. There is no acoustic shadow beyond that, because the ultrasound beam which actually strikes on the bone is completely reflected back. It doesn't go through the medium, so you don't get an image beyond the rib. So there's the rib shadow and there's a bowel gas. So some of the useful artifacts, what you see there in the first images, you find there's the acoustic image which is caused by the gallstones. You find a hyperechoic structure over there in the gallbladder, that's the gallstones. So some of the other images, what you see here is a bone spurs. So that again, bone is a hyperechoic structure that doesn't transmit sound waves. So there is no acoustic window beyond the bone. So what you find below that is acoustic shadow. It looks like anechoic area. And what you see there again is spine, which does not allow the transmission of sound waves, and it is seen as a hyperechoic rim of shadows over here. Now, this is a cystic area, which is a fluid contained cyst. What happens here is, what is the echo characteristics here is, the sound wave is completely transmitted throughout the fluid or the cyst, and it actually goes and hits on the posterior structure. And there is enhancement of posteriorly, which shows a hyperechoic structure beyond that. So this is just well delineated by the hyperechoic structure, which is over here beneath that, posteriorly beneath the cyst. So you can actually confirm it as a cyst or a fluid-filled structure. Now I'll just show you what is meant by a mirror imaging. So I'm trying to identify the subclavian artery and put a color Doppler over there. So what you see there is a color Doppler of the subclavian artery. Just beneath that, you can see another vascular structure, which is again pulsating. So that's a mirror artifact. Actually, what happens is the sound waves actually hit on, some of the sound waves actually reflect from the vessels, and some of the sound waves actually hit on the first strip and are reflected back and comes back and produces a mirror image on the screen. So you have a mirror imaging. Sometimes this is an artifact which is routinely seen when you go for a supraclavicular block. Now this scanning techniques, you can either do a sagittal scan or a transverse scan. This is how you keep the probe for a transverse scan. Scanning in the transverse, and this is the sagittal scanning. This is scanning in the sagittal plane. So you do either sagittal scanning or a transverse scanning. I'm just using a curvilinear low frequency probe. So what you see here is, again, I just want to show you the acoustic shadows by the bowel. So the bowel, there's a bowel underlying the abdominal wall. So what you see here is all bowel shadows being created by the bowel, air in the bowel. I just want to show you the acoustic shadow of the rib. I'm just doing a sagittal scan over the thoracic cavity. So you're going to see the ribs and pleura and the lung. So what you see there, the acoustic shadow which is being shown here, is the rib is overlying here. So the rib doesn't transmit any of the ultrasound beam. So what happens is you find an acoustic shadow beneath the rib, which above which you see the hyperechoic shadow. So that's a rib which shows a hyperechoic shadow, whereas this is a space between the two ribs which actually allows the sound to pass through, and you'll see the pleura and the underlying lung beneath it. Now I showed you about the scanning planes. Again, sagittal scan as well as a this is sagittal scan as well as a transverse scan. This is again a sagittal scan on the right side of the thoracic cavity, which is trying to show the liver. And this, what you see, the hyperechoic structure is the diaphragm, and you see the renal shadow. So there is overlying this, you have bowel, which shows which throws in a shadow, acoustic shadow. So something which you need to know about the ergonomics before you go and do an ultrasound. So always remember that the ultrasound machine should be positioned on the contralateral side of the patient, and you should be standing on the ipsilateral side to be blocked, examined. And always remember to hold the transducer in the non-dominant hand. So if it's a right-handed person, use the transducer, hold the transducer with the left hand, and tries to hold the transducer more towards the footprint area. And always remember that you need to manipulate the probe during needling, because it's a very thin 2 mm slice what you're going to see. It's a two-dimensional image. So bringing in the needle into the image is pretty difficult unless you learn to do it properly and with multiple attempts. So when you go for a out-of-plane probing with the needle, you need to actually tilt the probe to see the needle tip, which may be beyond what you see in the image, because you're just going to see the cross-section of the needle. It may be along the shaft to the tip. So these are some of the basics which I thought I'll just go through. And I think unless you practice on the patient with the ultrasound machine, adjusting all these settings, it's difficult to learn from the theoretical part alone. So I think next topic, when I think after 2 weeks, when I put in some more videos, it'll be more easier for you to understand all these applications of this physics and ultrasound for the anesthetic procedures. Thank you.
Thank you, Jitendra. It was a comprehensive discussion of the basics of ultrasound for anesthesiologists. And I think if you're okay, we'll take some questions that have come up in the chat box.
Okay.
There's a question, what is the difference between pulse wave and continuous wave Doppler?
I think Deepak sir would be able to bring in some of the images for continuous wave and pulse wave Doppler in next in his upcoming talk. I think. Sir, would you be able to detail on those things, pulse wave and color?
Yes, I can answer that right now. The pulse wave Doppler, you have a single transducer which emits the signal, strikes the object, and returns back to the same transducer. So that is what is pulse wave Doppler, and it can detect only low frequency velocities. Whereas in a continuous wave Doppler, you have two transducers. One will be two piezoelectric crystals. Let us see. One will be emitting the ultrasound continuously towards the object, and the other will be receiving the ultrasound continuously, so that the higher velocities can be detected by continuous wave Doppler. But the problem with continuous wave Doppler is that it detects the velocity, maximum velocity across the beam that is being hitting the object. Whereas in pulse wave Doppler, you can actually select the area which is called as the pulse volume, or the which you can position at a particular spot to know the velocity at that particular area. So low velocities, you use the pulse wave Doppler, and higher velocities such as aortic stenosis or wherever there is obstruction to the flows, the velocities are higher. So to detect the higher flow velocities, you need to use continuous wave Doppler, and for lower flow velocities, you need to use the pulse wave Doppler.
Thank you, sir. Another question that has come up is what is a phased array Doppler?
Sir, Deepak sir, can you just?
Sorry, I think I have lost the. Can you hear me?
Yes, sir, we can hear you.
But I didn't hear the question. Can you repeat the question?
So there's a question in the chat box asking what is phased array Doppler?
Phased array transducer. It is not Doppler. It is a phased array transducer, which means that there is a. If you can see my hand, if that is the transducer, it will emit pulses, 1, 2, 3, 4, and 5 pulses, and they will first pulse. After the first pulse goes and comes back, the second pulse will start. It comes back, then the third pulse will start. Likewise, all the 5 pulses will be fired in one go, and then again the first wave will be first pulse will be fired. So in this way, you fire the pulses in a phased manner, and higher the pulse number of pulses you fire, better is the resolution. So if there are 100 pulses going in one during one cycle, then and if the pulse repetition frequency is higher, the resolution is better. So that is what is the phased array transducer, which is used in cardiac imaging techniques.
Thank you, sir. How safe is ultrasound? Are there any side effects of using these probes? Jitendra?
Yeah. So see, as said earlier, ultrasound. See, you need to identify the structures first. Second thing is, like, when you use ultrasound continuously for imaging technique, you find there's some amount of ultrasound beam which is absorbed, and there's heat production. So what we have seen that there's heating up of the tissues. So when you use ultrasound for ophthalmic usage, there'll be heating up of the tissues, which is actually not good for the patient. So there is limitations again when you use an ultrasound probe. I said earlier, like, so when you have this thing, when you have the ultrasound being continuously used, the tissue gets heated up. We've seen one of our colleague who was working with us earlier, and she was continuously using the high frequency probe to identify the structures. That is her radial artery. What happened is, like, she was using a medium. You need to use a medium or jelly to actually get the ultrasound beam to have a contact with the skin and have an ultrasound beam passing through that to the tissues. So continuous usage, what has happened is she had got burns on the skin secondary to that. And some of the limitations which you need to identify the ultrasound is, again, When you use ultrasound for identifying structures in elderly patients or obese patients, the ultrasound beam what goes into the patient may not be reflected completely back. It can get scattered. The image clarity may alter. And when you have edema or edema underneath the skin, or when there's too much of fat underneath the skin, the tissues which needs to be identified beneath that may not have a good clarity. So there are limitations in using ultrasound probe in all these group of patients. And again, when you're using ultrasound probe is for needling technique, the problems what can happen is like you may overshoot the image, and actually the needle may be sighted a little away from what you see, and it can actually damage the structures. That's another limitation what is there with the ultrasound.
Another question that has come in the chat box is how to adjust the time gain compensation.
So what you've seen in the earlier video is like you've seen the time gain compensation, where you can actually adjust each level of the what you see on the screen is like you're adjusting gain at each level on the screen. So what you see there is like whatever structure you want to identify or whatever structure you want to visualize is usually kept at the center of the screen, trying to get the structure to the center of the screen. And that area is where you actually need to amplify the sound waves coming from those tissues. So actually you can, what you see in the earlier the video is like you can adjust time the compensation at each gain compensation, each level in the screen, and amplify the sound waves. So you need to adjust individually all those knobs what you've seen there on the machine. That's what is routinely done. So if you want to see a deeper structure which is to be identified better, you need to increase the amplitude of sound waves coming from the lower part of the screen. So you need to move the gain, the knobs towards the right to increase the gain. So the amplitude is increased from the lower part of the screen, the structures.
Essentially, the ultrasound coming back from the far field, it gets attenuated, and the image or the brightness that is produced is weaker, which can be enhanced by these knobs by turning them to the right in time gain compensation. So if you divide the image into near field, far field, and the middle field, the far field will be the least least visible or least clear on the screen. So you can enhance the clarity by increasing the bright. It is something like you increase the even you are listening to the music, if you increase the not volume, but if you increase the bass, something like that. So that kind of effect is produced by enhancing the ultrasound that is returning from the far field, and the image quality of these areas are improved.
So just before you start scanning, actually identify the structure, keep it at the center of the image, center of the screen, and then adjust the time gain compensation knobs and get the best image possible for you to proceed with the procedure. So you don't keep changing every now and then. So whatever image you have to get, whatever structure you have to visualize, identify that, adjust the gain over there. And like what Sarah said, if it's a deeper structure, you need to actually increase the gain on the lower part of the screen. So the deeper structures are visualized much better. Attenuation is not seen there.
Thank you, Jitendra. Thank you, Deepak sir. Deepak sir, would you like to add anything to this basic principles of ultrasound? Anything else? Which we
I think he has fairly well covered it, but the actual understanding will come when you have the hands-on on the machine. It is only then when you will understand the importance of TGC or brightness or depth. Or so essentially there are three controls which are very important to improve the quality of the image. Number one is the brightness. Second is the time gain compensation, and third is the depth, which has been very well highlighted by Dr. Jitendra. So there are other mechanisms such as focus. There is something called as focus or zoom, which can be used to enhance the quality of the image or focus your attention to a particular area of interest. So all these things are there, but essentially three things are very important: the brightness, the gain settings, and the time gain compensation, and the depth.
What does the question meant on tilting or rotating a visualized needle in plane mode?
Sorry, say again.
No, I didn't understand. What is the question? Tilting or rotating to visualize needle in plane mode?
How would you visualize the needle? Would you like to tilt or rotate the probe?
Yeah, actually, as I said earlier, in plane technique is the one to actually visualize the needle much better. And short axis view actually doesn't give you the full length of needle. So overshooting is always possible. So tilting, you do when you go for an out of plane technique where you actually see a cross-sectional view of the needle which is being introduced, but you don't see the tip. So if you don't see the tip, if you want to identify the tip, tilt the probe a little more discally. So what you see there is like you're going to see the tip of the needle, identify tip of needle. If you're in doubt, just do a hydrodissection and see with saline or with local anesthetic and see the tissue acoustics again. So rotating is basically when you put in a needle out of plane and then you rotate the probe clockwise or anti-clockwise to bring the image to a long axis view of the structure which is to be visualized. Then you see the in plane, you see the needle in full length, which is the in plane. In plane is always better for a beginner to actually do for any blocks or nerve blocks.
Thank you, Jitendra.
Yeah.
So probably after 2 weeks, you would be presenting the scenarios, right? On
Yeah, I think see, this is a bit confusing basically when you go on for just for physics of ultrasound. So I think it's better to go on for clinical applications, which can be.
We'll have clinical applications after 2 weeks from Jitendra.
I think that'll be better.
And before we move on to the next talk, I would like to announce the topics for the next week. That is 7th of August, Saturday, same time. We'll start with 2 topics. One is on ventilator-associated pneumonia, that is by Dr. G.V. Diwatia, who is Professor and Head of the Department of Anesthesiology and Critical Care at Tata Memorial Hospital, Mumbai. And this will be followed by an overview of long-term central venous access devices by Dr. E.K. Ramdas, who is Senior Consultant and HOD at BB Memorial Hospital, Calicut. So same time, please do join in next week. So we move on to the next topic, that is T in anesthesia practice. And to deliver this talk, we have with us Dr. Deepak K. Tempe, who is the retired Professor of Excellence in the Department of Anesthesiology and Intensive Care at G.B. Pant Institute of Postgraduate Medical Education and Research. He was the former Dean, Maulana Azad Medical College, New Delhi. Over to you, sir.
Thank you very much. Can you see my slides?
Yes, sir.
And am I clearly audible?
Yes, sir, you're audible.
Okay. Thank you very much. Many thanks, ISA Kerala, for having me for this academic activities. Special thanks to Dr. Venkat Giri, Dr. Nazar, and Dr. Vinil for this opportunity. And also thanks to Dr. Jitendra for making my job easier, because he has nicely highlighted the basic principles of physics that are used in echocardiography. Now this, I am told that mostly the students, MD, DNB and other students would be attending this talk, and also there will be some other people. So I would focus mostly towards the PG students and I would not go into the much details of this subject. However, I would like to emphasize that those of you who have come to learn to pass your examination, then if you do not know transesophageal echocardiography, you are not going to fail. So in short, this is not a lecture which is going to help you to pass your examination. It will help you to update yourself to the recent techniques that are used in anesthesia practice. And maybe at the end of this presentation, some of you will be inspired to become cardiac anesthesiologists. So as mentioned, this is one important aspect about the T that I would like to highlight is that it is an imaging technique, and it is a technique which is different than other imaging techniques such as CT scan or MRI, where the computer produces the image, whereas here it is the image quality is operator dependent. So the quality of the image, the structure that you want to visualize depends on your capacity, your caliber. And unless you are able to produce the image that you want to see, you cannot interpret it, and you cannot do the intervention that you propose to carry out in this particular patient. So with this background, let me start the presentation. I have nothing to declare, although I do not mind these days taking sponsorships. Now, let us try to answer why should a non-cardiac anesthesiologist know a TE? As you know that the number of patients, sick patients, those patients who have cardiac disease and are subjected to major non-cardiac surgeries on the increase nowadays. You get very sick elderly patients undergoing non-cardiac surgery such as cancer surgery or Whipple surgery or orthopedic surgery. And these are the patients in whom proper hemodynamic management would be very essential and which will make the difference in the outcome of the patient. So, although TE has well established itself in the cardiac operating room, it has found its way into neurosurgical operation theaters, and there are many neurosurgical operation theaters that have this machine in their theater. And it has also found its way in liver transplant OT, and it is likely to find its way gradually into other operating rooms over a period of time. I can foresee that this may happen in the next 10 to 20 years, just as the ultrasound is now almost an essential commodity of every operating room. The transesophageal echo would also become an essential commodity, and all that you need to have in the machine that was shown by Dr. Jitendra is to have a probe, transesophageal probe, and you can perform the transesophageal echo. So as I said, you have cardiac patients undergoing major non-cardiac surgery and other major non-cardiac surgeries such as obstetrics. Last week I was reviewing a paper, and a paper had shown that a patient who was undergoing cesarean section suddenly had hemodynamic compromise and collapse, and they had ready access to the echo machine and a cardiac anesthetist and a cardiac surgical team. So they put the patient on ECMO and the patient survived. So these kind of things can happen in any operating room, and maybe in times to come, transesophageal echo would definitely become a part and parcel of our everyday practice. So as mentioned by Dr. Jitendra, what you see when the ultrasound beam goes out of the piezoelectric crystals in a form of the sector that you see here, it produces a thin slice of a millimeter about thickness, and it produces an image of only that particular slice. So if I have to examine the heart, this is a transverse section of the heart at the aortic valve level. If I want to visualize the other parts of the heart, then I have to carry out series of sections at different levels. And this is an omniplane transducer that is used nowadays in transesophageal echo, so that this angle of this sector can be increased from 0 to 180 degrees. So I can section the heart in longitudinal section as well. And I can get various slices along the longitudinal plane as well as the transverse plane. So in this manner, the operator has to create an image in his mind and then take the decision about diagnose a particular condition depending upon the various sections that he is seeing. So this is the Doppler principle that was being discussed, and I'm happy that I have retained these slides. I've omitted most of the other slides. So when a still object, a pulse wave Doppler, the ultrasound beam will strike a still object, and the sound waves will return and hit the same transducer. Whereas in a patient who has in continuous wave Doppler, there will be two transducers, and one transducer to emit the signal and other to receive the signal continuously. Here what I'm trying to show is the Doppler principle. So when the object is moving, imagine an ambulance with siren on is moving towards you. You see that the frequency increases, the volume of the siren goes on increasing. This is because of the compression of the waves, and the frequency increases. And as the ambulance goes away from this place, you see again the volume of the siren goes down. So this is the principal, Doppler principle, who described the shift in the frequency as the Doppler shift, and he devised a formula which gives you the calculates the Doppler shift, and thereby helps you to calculate the frequency or the velocity of the moving object, which is the red blood corpuscle in the blood vessel. So that is how you measure the velocities. What is important here is that the angle of insunation, that is the angle on which the Doppler beam falls onto the moving object must be less than 20 degrees in order to get the accurate measurements. If the angle is 0, that means if the ultrasound beam is parallel to the direction of the blood flow, then that gives you the best calculations or the velocities, calculation of the velocities. So if the flow is laminar, as has been shown here, you get a clear spectral Doppler, as you can see here. Whereas if there is an obstruction to the flow, then you get a turbulent flow and you get a dense velocity, as has been shown here in the spectral Doppler. So here is one picture which shows the velocity profile across the mitral valve, and here is another which shows the velocity profile across the ascending aorta. So this is the transducer, and if the flow is towards the transducer, you get the upstroke, and if the flow is away from the transducer, you get the downstroke. So this is how you get the spectral Doppler, and it is used for based on the inbuilt software that is available in the machines. You can calculate the velocities and the gradients, and several other calculations can be performed. So what are the anesthesiologist's expectations? These are some of the expectations of a cardiac anesthesiologist. I cannot keep the cardiac anesthesia part absolutely away from this presentation. There will be some intermittently I would be referring to some of the cardiac anesthesia features of these machines. So the first thing that you want to do is to confirm the diagnosis. Are you really operating on the patient who has got the disease? You need to confirm that diagnosis again as a double check. Then you can use it as a hemodynamic monitoring tool. Now this feature of the machine can be used even in non-cardiac surgery. Any surgical procedure, the hemodynamic monitoring part of this machine can be exploited. So you can measure the volume status, that is the preload, whether the patient requires volume infusion or not. Then you can see the contractility of the myocardium, and you can also look at measure the cardiac output, and you can also measure the myocardial ischemia, or look at the myocardial ischemia by looking at the regional wall motion abnormalities. I'll show you some of the pictures during my presentation. And then if there is any other additional information that may be useful for the patient care, then the most important information that we find during cardiac surgery is the presence of PFO or presence of ASD, which has not been detected earlier, or presence of plaques, presence of clots, thrombus in the left atrial appendage. So these are some of the useful information that you may find as surprise findings. And also at the end of the surgery, you need to confirm the adequacy of the surgical repair or correction. If the VSD has been closed, you can ensure that the VSD has been properly closed. If the valve has been replaced, you can ensure that the valve has been properly placed and the cardiac function is restored to normal. So this is some of the statistics. We have seen that a change in the surgical plan, in the cardiac surgical plan, may be necessary from 3.4 to 27% of the patients. Now that's a large number of patients. So a patient who was scheduled to undergo a single valve replacement may end up undergoing double valve replacement. On the contrary, if a patient who is scheduled to undergo double valve replacement may end up undergoing only the single valve replacement. And likewise, there are several other changes in the cannulation techniques. The ones that I told you earlier are the major changes in the surgical plan, but there are several minor surgical changes in the surgical plan, such as choosing the site of cannulation, or if there is a left superior pulmonary vein, or then you have to use another cannula to cannulate the left superior vena cava, not the pulmonary vein, superior vena cava. Sorry. So as far as the recommendations for performing the TE in a non-cardiac surgical setup, the guidelines are very clear. There is a class 2A indication in emergency use of perioperative TE is reasonable in patients with hemodynamic instability undergoing non-cardiac surgery to determine the cause of hemodynamic instability when it persists despite attempted corrective surgery. Now, each and every word of this sentence is important. If the expertise is readily available. So if you have a person who is capable of performing an echo, then only there's a class 2A indication. But if the expertise is not available, then this is not indicated. Also, class 3 indication, there is the routine use of TE to screen for cardiac abnormalities or to monitor myocardial ischemia is not recommended in patients without risk factors. So you will not use this machine unless there are cardiac risk factors existing in a patient. For instance, a history of coronary artery disease, or history of congestive cardiac failure, or history of acute MI. And this patient has got a stent in place and now he's undergoing a major non-cardiac surgery. That's a person where you may like to use it for screening or monitoring the myocardial ischemia during the intraoperative period. So those are the guidelines, and these are likely to expand in times to come because this machine is so versatile, as you will realize at the end of this presentation, that each and every anesthetist would like to have this particular machine at his disposal if he is going to manipulate or play around with the hemodynamics of a patient. So that's the Philips machine that I'm going to show that we used to have, and that most of the pictures are obtained from this particular machine. And this is the probe. It is a gastroscope, endoscope, where the transducer is housed at its tip. And there is a handle here. Handle has got two knobs, circular knobs, the inner large wheel and the outer smaller wheel. And these are used to anti-flex and retroflex the tip of the probe or lateral flexion of the probe. In addition, there are two small buttons here which you may not see very clearly, but these are used to rotate the ultrasound beam from 0 degrees to 180 degrees. So if you have at 0 degrees, you get the transverse section, at 90 degrees, you will get the longitudinal section, and you will get several oblique sections in between 90 degrees and 0 degrees and 90 degrees to 180 degrees. And this is the close-up of the probe. That's the transducer which is housed in the tip of the probe. And like Dr. Jitendra explained the various movements of a handheld probe, there are certain movements which you need to perform with while you are using a transesophageal echo. And these are some of the standard terms that have been used in order to avoid confusion amongst each other. So when you say that the probe is being advanced, it means that it is being inserted inside. You don't use the term such as it is being pushed in or pulled out. So instead you use the term advance and withdraw for if you are going to pull it out. And if you are going to turn it clockwise, then it is called as turning to the right. And if you turn it anti-clockwise, it is described as turning to the left. And if you rotate the sector from 0 to 90 degrees, it is called as rotating forward. And from 180 to 90, it will be called as the rotating backward. So with the help of those small two buttons that I have shown you on the handle. Then this is the anterior flexion and the anti-flexion, and this is the retroflexion if it is flexed posteriorly, and this is turning to the flex to the right and flex to the left. So these are the four movements that you can perform. So the operator, while he's looking at the screen, he has to with the right hand, with the left hand, he should hold the handle, and with the right hand, he is manipulating the probe. So there is a lot of hand-eye coordination that is necessary in order to obtain the image of your interest on the screen, and that this needs practice. And it's very easy to practice this. The more you do, the more familiar you become and more expert you become in producing the good quality image. The interpretation part is still difficult, and I can say that I am still learning to interpret. Over the years, you keep on learning interpretation of the image, and then how to intervene or how to take various measures depending upon the image interpretation. But the primary requirement is to produce a good quality image, and that will be the focus of this particular presentation. So there are various levels at which you can section the heart. This is the upper esophageal section. Then you can go to the mid esophageal level. Then you can insert the probe into the stomach and get the transgastric sections. And you can go deep into the transgastric, anti-flex the probe and section the heart from the front, that is from the ventricular side. And this is the deep transgastric level. So these are the four levels of sectioning of the heart that you will be utilizing in order to obtain the images. Now this video is going to show you how to insert the probe. This is a very simple video which shows how easy it is to insert the probe, especially in an unconscious patient who has got an endotracheal tube. So you anti-flex the probe slightly, lubricate it nicely, and you just insert it with gentle pressure. It goes in very easily. So this is how you should insert the probe. Now, few things I would like to highlight here is that although it is very easy to insert the probe without the use of the laryngoscope, please do not hesitate to use the laryngoscope in case you encounter even the slightest of the resistance, because the mechanical injuries are there in the patients in the upper airways, and also if there are any esophageal bleeders or varices, then it is likely to injure those varices. And also there are reports in the literature of esophageal tear in a patient who had a Barrett's esophagus, and also injury to the liver and to the airways in children. The probe can obstruct one of the bronchus. So all these problems are there, although the incidence is very less. I'm not trying to frighten you. This can be very easily overcome by being a little bit more cautious than, don't feel, ashamed of using the laryngoscope. Don't make it a prestige issue that I had to use the laryngoscope. If you encounter a slightest resistance toward an insertion of the probe, don't hesitate to use the laryngoscope, and you can avoid the injuries to the patient. Now, there are 20 standard views that have been described for examination of the cardiovascular system by the American Society of Anesthesiologists. There are 2 upper esophageal views, there are 12 mid-esophageal views, and there are 6 transgastric views. And they are named, and there is standard names. So mid-esophageal 4-chamber view, mid-esophageal 2-chamber view, and likewise. Although they appear very complicated, they are not difficult to understand, and I am going to show most of these views, maybe about 16 views at least, which are very simple to obtain. They are not very difficult to obtain, and they can, provided you understand how the simple techniques of obtaining these views. So that will be the first part of my presentation to make you familiar with the various views. So let me start with the mid-esophageal 4-chamber view. So at the esophagus, the probe is at around 30 centimeters on the esophagus at the level, and the transducer angle is 0 degrees. So this dial on the screen shows what is the ultrasound beam angle. So this is the 0 degrees here, and at about 30 centimeters of insertion from the mouth or the incisors, you see this picture, which is a 4-chamber view. So you see the left atrium, mitral valve, left ventricle, right atrium, tricuspid valve, and the right ventricle. So this is the easiest of the views to obtain, and you can interrogate the mitral valve and also the interventricular septum and the lateral wall of the myocardium. So it's very easy view, and I describe this as you make it a home page. So whenever you get lost in the middle of the echocardiographic examination, come back to this view, because this view is very easy to obtain, and start again. So that's the home page of your examination of the transesophageal echo. So at 30 centimeters at 0 degrees, you get this view. Leave the transducer at the same position and increase the angle to about 90 degrees to get the 2-chamber view. So now you are sectioning the heart longitudinally, and what you see is the 2-chamber view. As you can see here, the left atrium, left ventricle, and the mitral valve interpose. And what you must see is the left atrial appendage. So the classical 2-chamber view means you must be able to see the left atrial appendage. This is the anterior leaflet of the mitral valve, and this is the posterior leaflet. This is the anterior wall of the myocardium, and this is the inferior wall. So if you are interested in evaluating the regional wall motion abnormalities, you should know what part of the myocardium you are seeing. So at 90 degrees, you get this view. Go on increasing this angle to about 110 degrees, and you will see what is called as the mid-esophageal long axis view, as you can see here. So I have increased the angle to about here. You see about 125 degrees. What I see here is the left atrium, mitral valve, left ventricle, the left ventricular outflow tract, the aortic valve, and the ascending aorta, and a part of the right ventricle. So excellent view to interrogate the mitral valve and the aortic valve. And the 2 walls of the ventricle that you are seeing is, this is the anteroseptal and this is the inferolateral wall. So again, if you are familiar with the myocardial segments, and if you are interested in knowing a wall motion abnormality of a particular segment, you should know that this is the anteroseptal and this is the inferolateral wall. Now leave the probe at the same position, and you can decrease the angle to about 60 degrees, come back to about 60 degrees, and what you see is the commissural view. And the commissural view shows, it is also called as seagull view. As you can see, this is the bird flying, there's a seagull, and these are the 2 wings. So it looks like a seagull. So that's the A2 segment of the mitral valve. This is the P1 segment of the posterior leaflet, and this is the P3 segment of the posterior leaflet. So you see actually 2 commissural, two cooptation points here. And as you can, this is also called as trapdoor view, because as this A2 segment of the mitral valve is opening and closing like a trapdoor. So this is also described as a trapdoor view. So that's another view. So set of 4 views I have shown you. At one transducer placed at one position, you have only changed the angle of the ultrasound beam from 0 to 90 degrees, 90 to 120 degrees, and 120 back to 60 degrees. And you are able to produce six beautiful views. Now let's move on to the another set of 4 views you can produce by without manipulating much of the transducer. And this is the aortic valve short axis view. For this is obtained at about a transducer beam at an angle of about 30 degrees. So this beam you can see is not perfectly at 0 degrees, it's slightly tilted, because the aortic valve annulus is not parallel to the ground. It is slightly vertical, slightly tilted, and that's why you need to tilt this angle to about 20 degrees. For this, you obtain the 4-chamber view, withdraw the probe a little bit, and increase the angle to about 20 to 30 degrees, and turn the probe to the right little bit. and you will start seeing the aortic valve in short axis. So this is the best view to interrogate the aortic valve. You see the right coronary cuffs, the left coronary cuffs, and the non-coronary cuffs. So nice co-opting a normal aortic valve can be seen here. If you withdraw the probe slightly, the aortic valve disappears, but what you start seeing is the left main coronary artery. So you can also evaluate the coronary vessels here with the help of echocardiography. So the beauty of transesophageal echocardiography is that it is very versatile, and if you are familiar and if you produce the images, you can visualize almost any structure in the heart and can interrogate and evaluate the function of any part of the heart. So that is the first view, and now the second view would be to increase the angle to about 60 degrees. Don't change the transducer position, just increase the angle from 30 to around 60 degrees with the help of those two buttons, and you will see the I think this is the aortic valve long axis view. So I have increased the angle to about, sorry, this is the aortic valve short of RV inflow outflow view at around 60 degrees. You will see that I can see the left atrium, the right atrium, the tricuspid valve, the right ventricular inflow, and the right ventricular outflow. You can see it better here. So that's the inflow. You see the tricuspid valve and the outflow. You can see the pulmonary valve here and the pulmonary artery. And look at this, the free wall of the right ventricle, which is contracting very well. So this view is very important to also evaluate the free wall contractility of the right ventricle, in addition to evaluate.
Sir, you are not audible. Deepak sir?
I think it's stuck. It's stuck now. I think we have to call him on mobile. Presentation is stuck now.
No.
Sir is joining. He got disconnected. He is joining back.
Can you hear me?
Vinil sir is back.
Yes, he is back.
Okay.
Yes, sir, we
Sorry.
can hear you now.
Yeah, I had lost my connection and I have got it back. Can you see my slides?
Not yet, sir. Not yet.
Okay. So can you see it now?
No, sir.
No?
No.
No, sir.
So I think I have to unshare and share again. Just give me a second.
Yeah, sure, sir.
Can you see now?
Yes, sir.
You can?
Yes, sir, we can see.
Okay. So I think I was on this slide explaining the RV inflow outflow view.
Yeah.
Am I correct? Okay.
Yes, sir.
So you can see the tricuspid valve and the pulmonary valve and the free wall contractility. That's the benefit of this particular view. And if you increase the angle to about 110 degrees, you can section the aortic valve in long axis, and this is called as aortic valve long axis view. So we are not changing much of the transducer position. We are only playing around with this dial. We are only changing this angle, and we are getting all these beautiful views. So this is similar to mid-esophageal long axis view that you saw. So you see the left atrium, mitral valve, the LV, and the LVOT aortic valve and the ascending aorta. So assessing the mitral valve and the aortic valve is possible, easily possible with these views. And leaving the probe at the same position, if you turn the probe now to the right, so this beam was earlier on this side, and we have now turned the probe to the right. So it sections the superior and inferior vena cava, and you get what is called as the bicaval view. So you see the superior vena cava here, the inferior vena cava will be somewhere here in the coronary sinus. And this is the left atrium, this is the right atrium, interatrial septum, that's the fossa ovalis site for the patent foramen oval, which can be present many patients. And that's the PA catheter that you can see in this particular patient, which was inserted in this patient. So that's the set of next 4 views. And let me move to the next 4 views. I will show only 2 of the views. One of them is the mid-esophageal ascending aorta short axis view. For obtaining this view, you go back to the aortic valve short axis view and withdraw the probe. So the aortic valve disappears from the view, and what you see is the ascending aorta, and you can examine the entire length of the ascending aorta till the right main bronchus, where there is a blind spot because there is a air-filled bronchus in between the aorta and the esophagus. You cannot see that particular part of the aorta. In this view, you also see the right pulmonary artery and the main pulmonary artery, and the left pulmonary artery will be on this side, which is difficult to visualize. So if you are placing the PA catheters, you can actually check that the PA catheter is in proper position with this particular view. Now this is obtained at about 0 degrees. If you increase the angle to 90 degrees, you get the ascending aorta long axis view. So about 8 to 10 centimeters of the ascending aorta can be visualized with the help of this particular view. So those are the two views. You can also see the descending thoracic aorta, long axis and short axis, by turning the probe to the left, but I am going to skip that. And let me now move on to the transgastric views, so that I have inserted the probe into the stomach, and I can section the ventricle from left ventricle by inserting the probe into the stomach. And the most important view that the anesthesiologists like to see is the transgastric mid-papillary short axis view. So what you see here is the transverse section of the left ventricle. That's the anterior wall. This is the inferior wall. This is the interventricular septum and the right ventricle on this side, and that's the lateral wall. And these are the 2 papillary muscles. This is the anterolateral and the posterior medial papillary muscle. And this is a very important view because it gives you 3 kinds of information. Number 1, it shows you the volume status. Now this is a normally filled left ventricle, so you know that the volume status is okay. Then it shows you the contractility. So the ejection fraction of this particular patient is at least 50%. So there is a good ejection fraction. The third thing that it tells you about the regional wall motion abnormality. So there is no regional wall motion abnormality here. And this is very important because the myocardium supplied by all the 3 coronaries is displayed in this particular view. So that is the LAD area, this is the circumflex area, and this is the right coronary artery area. So depending upon the area that is hypokinetic or akinetic, you can understand as to which coronary vessel is involved. Even that kind of information can be gathered from this particular view. And if you withdraw the probe from this position, little bit, you start seeing the mitral valve. And you can see that this mitral valve is opening and closing. This is the anterior leaflet of the mitral valve. This is the posterior leaflet. So this is called as the basal view, basal short axis view, transgastric basal short axis view. Now leave the probe in the same position, increase the angle from 0 to 90 degrees. You see the transgastric 2-chamber view. So that's the left atrium, and this is the left ventricle. This is the anterior wall, and this is the inferior wall. This is the anterior papillary muscle. This is the posterior papillary muscle, and these are the chordae. So this is an excellent view to examine the subvalvular apparatus. And this is the dynamic image. You can see that the anterior myocardium is contracting very well. This is the inferior wall, this is the left atrium and the left atrial appendage. So lots of information can be gathered by these two views. Now, in the same position, if you increase the angle to about 110 degrees, you see what get the view which is called as transgastric long axis view. And what you see here is the aortic valve comes in a picture here. So you have the left atrium here, mitral valve, and the LVOT and the aortic valve here, and the ascending aorta. So the alignment of the Doppler beam is fairly good here. So you can measure the aortic valve or LVOT flow velocities and thereby measure the cardiac output of the patient. So that's the color Doppler. You see the laminar, nice laminar flow, blue color going away from the transducer across the aortic valve and LVOT. You can place the pulse wave Doppler here at this particular spot. So you measure the velocity profile of this particular spot. So that's the difference between the pulse wave Doppler and the continuous wave Doppler. In the continuous wave Doppler, it will measure the velocity, highest velocity all along this path. Whereas in pulse wave Doppler, you can measure the velocity at a particular given spot and the LVOT in this particular patient so that you can measure the cardiac output. Because the alignment of the Doppler beam is almost 0 degrees with that of the direction of the flow of the blood. And then you move on to the deep transgastric view. So the transducer probe is advanced into the stomach. The probe is anti-flex so that you section the left ventricle first as against the left atrium in all these earlier views that you have seen. And you see the picture something like this. So you see the left atrium, the anterior mitral leaflet, the posterior mitral leaflet, the left ventricular outflow tract, and the aorta. Now the alignment of the Doppler beam is the best in this view, so that if you want to measure the cardiac output, this is the best view. But unfortunately, this is the most difficult view to produce. Although it is difficult, with little practice, you can produce it in almost all the patients. So you see here the dynamic picture of this view. You see the left atrium, anterior leaflet, posterior leaflet of the mitral valve, the LV contracting well, that's the interventricular septum, the right ventricle, LVOT, aortic valve, and the ascending aorta. So this view is best for evaluating the aortic valve flow velocities. So any aortic stenosis will show you increase in the velocities, and also it will help you to measure the gradients across the aortic valve. And this is the spectral Doppler that you obtain. And if you encircle this velocity profile, you get the what is called as the velocity time integral, which is equal to the stroke volume. So if you multiply this by the diameter of the or area of the LVOT, which is obtained by measuring the diameter and applying the pi r square, you can measure the stroke volume and multiply it by the heart rate, you get the cardiac output. So you can also measure the cardiac output in these patients. All the calculations are done by the inbuilt software that is present in the machine. All you need to get is these views and this spectral Doppler profile and measure the velocity time integral and the diameter of the LVOT. The next view that I'm going to show is the aortic arch. This can be obtained these are the upper esophageal views, and you have to withdraw the probe much above the mid esophageal views. Here you can see the aortic arch in the longitudinal section. This section is obtained at 0 degrees because the arch is placed horizontally. It is not it is a structure which is a transversely placed structure, obliquely placed structure in the thorax. So the longitudinal section is obtained at 0 degrees, unlike most other structures where the longitudinal section is obtained at 90 degrees. Instead, in this aortic arch at 90 degrees, you get the short axis view or the transverse section of the aortic arch, as has been shown here. By increasing the angle, I have obtained the transverse section of the aortic arch. You also see the pulmonary artery and the pulmonary valve in this particular view. So there are a variety of uses. So pulmonary thromboembolism can be diagnosed if you are suspecting pulmonary thromboembolism. So the diagnosis can be provided by the transesophageal echocardiography. So this video shows the examination of the entire aorta right from the abdomen. So I have placed this probe in the abdomen, and I have rotated it by 180 degrees. So the transducer is now facing the posterior aspect of the dorsal aspect of the patient, and in the aortic valve, the descending aorta, abdominal aorta has been sectioned. Now, if I withdraw the probe gradually, keeping the aorta in the center, I can go up to the arch of the aorta. So if you can see, I can examine the entire length of the descending thoracic aorta by this particular maneuver, right up to the aortic arch. So I have shown you almost all the views, except that this is one more view which I would like to show. This is a hepatic vein view, and this is the inferior vena cava. You have know the importance of inferior vena cava in estimating the volume status of the patient. So this is a nicely filled inferior vena cava, not much of pulsatility. So this is a nicely filled inferior vena cava. I obtained this view, the cardiac anesthetist obtains this view to locate the position of the IVC cannula that the surgeon has inserted. So this cannula has gone beyond the hepatic vein, so that's not the ideal position. But for you, you can use this view to estimate the volume status of the patient. So that completes my some of the views that I would have liked to show you. These are some more additional views, and there are many modified views. So there can be innumerable views that you can obtain in this in a patient in order to evaluate the cardiovascular system. So let me now move on to some of the issues related to hemodynamic management, and the most important application of the TE in non-cardiac surgical setup is to manage the hemodynamics. So I would like to take help of this view to explain you the Starling curve. On this axis, you have the stroke volume or the cardiac output, or let us assume that cardiac output is equal to blood pressure. And on this axis, you have the initial fiber length in terms of the central venous pressure. And in a normal patient, you see a waveform. This is a diagrammatic representation. The normal waveform which shows that as you increase the CVP, the cardiac output or the blood pressure increases. So this is what the normal wave is. As against this, if you see a failing heart, although you increase the CVP, the cardiac output or blood pressure does not increase. So by this, you must, when you monitor a patient, you must place your patient on these particular Starling curves and find out to which curve your patient belongs. And you can divide this figure into 4 quadrants. If the patient is in this quadrant, where the CVP is low and blood pressure is low, you need to administer volume to this patient. And if you are in this quadrant where the CVP is high but the blood pressure is low, it means that the myocardial contractility is not good and you need to administer inotropes to this patient. If your patient is here, he is overfilled, he needs vasodilators or maybe Lasix or diuretics to decrease the intravascular volume, and you want your patient to be here. So all the hemodynamic monitoring that you perform is with the objective of managing this patient, whether to infuse volume or whether to use inotropes or whether to infuse volume and inotropes both. After administration of volume, your patient may go here. So in case he goes here, you need to administer inotropes to this patient. Now the problem with the pressure measurements is explained in this particular figure. I will try to explain you the pressure volume relationship of the good ventricle or a compliant ventricle. You know the property of the ventricle is that it is a very compliant structure, which means that if you fill the ventricle with a lot of volume, the pressure doesn't go up. Just as the alveoli, when we say that they are compliant, means that if you fill up the alveoli with a lot of air, the airway pressure doesn't go up. Likewise, in a good ventricle, although you fill the ventricle, the pressure doesn't go up. So this is a normal patient. So you can see that in a normal patient, there is not much change in the pressure, although there is a lot of change in the volume. Against a patient who has got a failing heart, there is the curve is steep, you know, as you increase the volume, the pressure goes very high, steeply. So you can notice that in this particular curve, there is a large area of the curve where there is significant change in the pressure, but not much change in the volume. As against this curve, where there is a significant part of this curve, there is a large increase in the volume, but not much increase in the pressure. So because of this abnormality, the pressures do not reflect the volume status adequately. And that's where the transesophageal echo comes in picture. And you can know the volume status. As I showed you in the earlier picture, that's a normally filled ventricle. And this is a ventricle which is rather overfilled and which needs to have some vasodilators or maybe diuretics. As against this patient who has aortic stenosis, in the underfilled patient, you see the papillary muscles are almost kissing each other. So this we describe as kissing papillary muscles. And this patient requires volume infusion irrespective of the CVP or the pulmonary artery pressure or wedge pressure in this particular patient. So the volume status, contractility, and the regional wall motion abnormalities, which can be identified, and appropriate therapy can be administered to the patient. This I already explained to you how the cardiac output can be measured. So you get the spectral Doppler and you apply this formula. Velocity time integral is obtained by enveloping this particular spectral Doppler waveform. multiplied by the cross-sectional area of the LVOT and multiplied by the heart rate. All the calculations are built in software, and all you need to do is just to obtain the image and measure the velocity time integral and the diameter of the LVOT, not even the cross-sectional area. So, in hemodynamic, any hemodynamic instability, if it is there, it is not responding to normal therapy by way of volume infusion or inotropes, you need to use the transesophageal echo, and that is what the ACC AHA guidelines also say, that if there is no response to the usual treat therapy, then you should do the TE assessment, and you get the instant information about LV filling, global contractility, and regional wall motion abnormalities. You may come across a diagnosis of surprise pericardial effusion, which is not reported earlier, and also cardiac tamponade. So, instead of administering volume or inotropes, you need to perform pericardiocentesis in this patient. And this we have seen in our practice. Or pulmonary embolism, I have shown you the ascending aorta, upper esophageal arch of the aorta, short axis view, which shows the pulmonary artery very nicely, and also the ascending aorta short axis view, which shows the right pulmonary artery and the main pulmonary artery. So any thrombi can be visualized here. And if there is any additional and sometimes unexpected information can also be obtained. This has often been seen in the ICUs and in the cardiac operating rooms, that your patient is not responding to usual therapies, and you put the T probe and you sometimes suddenly get an unexpected finding by way of maybe endocarditis. So there you see some vegetations, you might see a thrombus sitting somewhere, or you may see the pericardial effusion or something like that. And it often leads to change in the therapy, and the patients, they improve. So now I'll show you some interesting images. I have shown you most of the normal images. Let me show you some abnormal images. So if you see this picture carefully, this is a transgastric short axis view. You watch all the walls of the ventricle. They are thickening nicely, except this, which is the anterior wall, which is not moving towards the center and also not thickening. So this is the anterior wall hypokinesia, the LAD territory. So there is a lesion in the LAD territory. So if there is any new regional wall motion abnormality, so any old regional wall motion abnormality is not significant. So if you see that there is this wall motion abnormality which has appeared now, it was not there earlier, which means that there is a anterior wall ischemia, most probably because of the LAD occlusion. And this picture shows you what is a hypokinetic ventricle is. Just try to compare it with the earlier ventricles. So you see that the inferior wall in the septum is almost akinetic. The only area that is moving is this. So this patient will require a lot of inotropes, as against this patient who is almost akinetic. Now this ventricle is not moving at all. So he is going to require, inotropes are not going to be sufficient. He's going to need some mechanical support, such as intra-aortic balloon pump or some such thing. This is a picture shows the right ventricular failure. Again, a transgastric view. This is a very rare picture. You see this is the left ventricle and this is right ventricle. Look at the size of the right ventricle, almost 3 times the size of the left ventricle. So this is a globally dilated right ventricle and almost akinetic. It is not moving at all. And it is not able to pump blood into the left ventricle. Therefore, the LV is very small. So although it is contracting vigorously, it is not able to pump any cardiac output because it is not receiving blood. The reason here is the right side, not the left side. The LV contractility is good. So normally we don't see the right side, and we would treat this patient by giving inotropes and volume infusion, and will only worsen the right ventricular failure. So this patient requires inotropes such as milrinone or inhaled milrinone, or restriction of the volume. So this is how surprise findings can be seen. This is a picture of mitral stenosis. You see the left atrium. This is a long axis view, aortic valve long axis view. You see that's the aortic valve. This is the left atrium. And this is the mitral valve. And this is the left ventricle. This is the LVOT. See the size of the left atrium is bigger than the left ventricle. And you see the calcified tips of the mitral valve here, and also classical hockey stick appearance of the anterior mitral leaflet. I have frozen this image. You see that's the handle of hockey, and that's the tip of the hockey stick. So that is what we describe as hockey stick appearance of the mitral valve. And this is the spontaneous echo contrast for the in the left atrium. That is because of the stasis of the blood or the smoke in the left atrium, as has been described classically. So that is how the mitral stenosis looks like. This is a picture, four-chamber view showing the mitral regurgitation jet, the turbulent. So this, you don't see the red and blue, you see the mosaic here. So that's a turbulent flow. Anything that is not red and blue and a mixture of colors is the mosaic flow. And it is in systolic flow. During systole, it is entering the left atrium. So the mitral valve is incompetent. And here you see the long axis view of the aortic valve. You see the jet of the aortic regurgitation going into the left ventricle. So this is just to show you some interesting pictures. This is a picture of the left atrial myxoma. Normally the myxomas are described as mobile structures, but we encountered a patient who has a immobile atrial myxoma, histologically proven atrial myxoma. Normally the myxoma is like this. It is a mobile structure. From the left atrium, it is entering, trying to enter the left ventricle. And mind you, sometimes these patients, they are asymptomatic many times, and they can be subjected to non-cardiac surgery, or sometimes they present with stroke, and then you detect the left atrial myxoma. This patient has got the right atrial myxoma. Normally the myxomas are common in the left side, but here you see the right atrial myxoma trying to enter the right ventricle here during each cardiac cycle. Then I want to show you some of the thrombi. How does the thrombus looks like? This is a thrombus in the left atrium, large thrombus. Usually it is an immobile structure, and this is a dense, echo-dense structure. Normally, because this is an organized thrombus, as against this thrombus, which is relatively fresh, it is in the left atrial appendage. It is not as dense as this patient. And this is a patient with mitral stenosis, so large left atrium and a thrombus there. And sometimes surprise item is, this is a patient who had a thrombus in the left atrium, which is almost mobile, like a ping pong. It is going from one place to another. And we removed this thrombus, and histologically proven to be a thrombus. We didn't know the diagnosis before the histology was performed. So these are some of the interesting images. Lastly, I would like to show the air bubble, because this is very important. You see, these are small microemboli of the air bubble, which are of the size of the right red blood corpuscle, and these are not very significant. We see often these pictures in the after terminating the cardiopulmonary bypass. But what is more important is to be on the lookout for a large air bubble, which you see as a linear echo density with a dirty acoustic shadow. So because the ultrasound is reflected, all the beams that are striking this air bubble are reflected back. It casts a dirty acoustic shadow, and it is also mobile. It almost appears like a foreign body in the left atrium, but this is an air bubble. So before you terminate the bypass, you must remove this air bubble completely, and then only terminate the bypass. So finally, one or two cases just to complete my presentation and to reinforce why I say that echocardiography is so important in a cardiac setup, and it is going to be important in a non-cardiac setup very soon, maybe in another 10-20 years. So this case report we published in a patient who had undergone an uneventful ostium secundum ASD closure, and we terminated the bypass. We found that this successfully terminated. PO2 was 44 and saturation was 80%. And manual ventilation to expand the lungs did not help much. Suctioning also did not help much. So we felt that there is something wrong with this patient. We performed the transesophageal echo bicaval view. We found that it's a left atrium, right atrium. That's the patch that has been interposed by the surgeon. This is the inferior vena cava, and we noticed that there is some small opening from IVC to the left atrium. And we see the dynamic image, you see that there is some opening here. So in order to confirm this opening, we performed the agitated saline contrast. We injected some saline into the central venous catheter that was in the right interjugular vein. And we did see some contrast appearing in the left side, although there is only very little contrast appearing. But thinking that IVC is opening into the left atrium, we cannulated the femoral vein and injected the contrast into the femoral vein, and you see how it appeared. The entire contrast appeared into the left side. And this is the first frame. It has entered the left atrium, and in the next frame, it filled the left ventricle completely. So there was no doubt that there is a shunt from the IVC to the left side, and we went back on bypass in this patient. And what we observed was that this is again, let me explain you the anatomy. This is the left atrium, right atrium. This is the patch that was placed by the surgeon. He had placed the patch to this structure, which is the enlarged eustachian valve. This is a normal structure. It can be enlarged in some patients. So the surgeon, by mistake, considered this to be the inferior margin of the septal defect and anastomosed this patch here, leaving the IVC open to the left atrium. And this is the coronary sinus. So he removed this patch from this place and placed it at appropriate position. And you see that when we injected the contrast, again, the contrast stayed on the right side. So there was no, so this defect was repaired on the spot, on the same operation, in the same operation. In the absence of T, this patient would have been discharged, and or maybe we would have detected it later on during the next visit, and then he would have undergone the second operation. The another case I would like to show this highlights the utility of T in guiding the PA catheter insertion. In a patient with aortic stenosis bicuspid valve, we were inserting the PA catheter as a part of some research activity. And the first surprise we got that his PA, this was the RV pressure waveform. So after you negotiated the catheter across the tricuspid valve, we reached the RV, and we found that the first surprise was that the RV pressure is very high, 75, which we do not expect in aortic stenosis, except in late stages when the PA pressures can go up in a patient with aortic stenosis. You may get pulmonary hypertension and the RV pressures going up. But that was the first surprise that we got. And we tried to insert the catheter further, and we found that we are getting these venous waveforms. We were imagining that this catheter is flowing retrogradely back into the right atrium again. Repeated attempts, revealed the same thing. So we inserted the TE probe. So this is how we got the RV continuously, and when we advanced the catheter further, we got this particular venous waveform indicating as if this is coming back into the right atrium. So we inserted the TE probe and we evaluated this is a modified view. So this is the RV inflow outflow view. You see the RV outflow here. That's the pulmonary valve. This is the main pulmonary artery. So we stationed the catheter here in the RV, and we got this particular RV waveform very clear here. Now we advanced the catheter further and confirmed on TE that it is in the PA. So it is in the PA, but we got the same waveform. So with this indicated that this patient has got something to do with the pulmonary valve. We examined the pulmonary valve and we found that there is a doming of the pulmonary valve. It is not opening well. And on color Doppler, we found that there is turbulence across this valve. And another view, we found that this is the bicuspid aortic valve. You see the bicuspid valve, the two leaflets, 1 and 2. And this is the pulmonary valve, which is also bicuspid. So this is a stenosed pulmonary valve. So this patient who was scheduled to undergo only aortic valve replacement now underwent pulmonary valvotomy as well. So in the absence of T, this was an accidental finding, but if you would have done the T properly in this particular patient, you would have performed, you would not have missed this. So that's the importance of the transesophageal echocardiography. This is my last slide, which shows the what is called the systolic anterior motion. So now when the interventricular septum, this happens in the athletes where the interventricular septum is hypertrophic obstructive cardiomyopathy, HOC, you might have heard this term. Football players, they collapse on the field. It is because of this mechanism that when there is a narrowing of the LVOT, so the blood which has to flow from here to the ascending aorta, because of the narrowing of this hypertrophic septum, because the ventricle has hypertrophy, it pulls the AML by venturi effect towards the septum and produces the mitral regurgitation. So there are two things happening. One is that there is not enough stroke volume, and the other thing is the mitral regurgitation. So the treatment of this condition is very simple. You need to use the vasopressor and beta blocker. So you slow down the heart and constrict the peripheries, and you can correct this condition very easily. So the hypotension in this patient was very easily corrected. You see that the MR has disappeared, and this is a view is slightly different than the one I have shown here. This is a 5-chamber view. So the aorta is here. This is a long axis view of the aortic valve. So the aorta is here. You see that there is a laminar flow now in the ascending aorta, and the MR has disappeared. So simple medical therapy has restored the normal hemodynamics, which would not have been restored by infusion of volume or inotropes. So if you ask me when should you perform the T, the answer is always, always, always. And thank you very much for your kind attention. I hope I have made my point by emphasizing how important, how versatile this particular tool is, and it is now accessible to the anesthesiologist. The cardiac anesthesiologists have exploited it fully, and I believe in times to come, even the non-cardiac anesthesiologists, those who are particularly dealing with sicker patients, sick cardiac patients undergoing non-cardiac surgery, they will find it extremely useful, not only in the operating room, but also during the post-operative. So thank you very much for your kind attention.
Thank you, sir. Thank you, Tempe, sir, for that detailed discussion on TE in anesthetic practice. So could you tell us the dimensions of these adult probes?
Sorry, dimensions of?
The adult TE probes.
Oh, the TE probe is around 10 to 12 millimeters. So it is about a centimeter or centimeter. It is like a endoscope. Have you seen a gastroscope? It
Yes.
is almost like that. But nowadays we have the pediatric probes as well, which have got a diameter of even 4 millimeter and less. So infants and neonates also we can insert the probe in the infants and the neonates as well. So, but those probes are more expensive. Yes.
So what would be the minimum weight in which these probes can be inserted?
I think I have inserted about 25 kilos patient, this probe can be inserted.
So below 25, we would not insert an adult.
If it is definitely, if there is a class 1 indication, I will make it go. If it goes in easily, I would quickly do it and do a T and come back. So it depends on the indication. So like I mentioned about the Barrett's esophagus patient getting a tear in the esophagus, that patient had a class 1 indication, mitral repair. He was undergoing mitral repair, and mitral repair has got a class 1 indication for performing TE. That is why TE was being performed there, but the operator may have played around a little more with the probe, and he there was a tear in the esophagus which required surgical repair. So it depends on the indication. If you badly need the TE examination, then of course it is you can insert in a smaller patient. But transthoracic, most of the images that I have shown on transesophageal echo can also be produced by transthoracic echo. But the problem with transthoracic echo is that it is while performing thoracotomies or abdominal operation, you cannot do it. So in an intubated patient, this TE probe stays in situ and it's without disturbing the surgeon. Or in a post-operative period when the lungs are being ventilated in the patient who is on ventilator, the acoustic window of a transthoracic probe is very, very bad, and you cannot see most of the structures as well as you can see on the transesophageal echo. So these are the areas where the transesophageal echo scores over the transthoracic echo.
Yes, sir. So do you alter the scanning frequency in your practice?
We don't alter the frequency. The frequency is usually fixed. The frequency changes automatically as you change the depth of the patient or when you apply the color Doppler. So the frequency alters depending upon the sector width that you have chosen or the depth that you have chosen. The frequency is adjusted automatically. You do not need to alter the frame rate or the frequency rate in this transducer.
Thank you, sir. There are two questions in the chat box, sir.
Yes.
One is on use of 3D imaging versus 2D in TE.
Yes, no doubt 3D imaging offers you more information as compared to 2D imaging. But let me tell you that so far the guidelines do not say that, for example, the volume measurements are supposed to be better with the 3D imaging. And before that, let me also say that the 2D is the fundamental echocardiography that you have to do and you have to know and you have to perform before you proceed to the 3D imaging technique. So if you do not know 2D imaging, you will not be able to perform the 3D imaging. Like I mentioned, the volumetric measurements are considered to be better with the 3D because there are no imagination or no formulas applied, and you do not hypothesize that there is a cylinder or there is a conical structure lying. The actual volumetric measurements are performed. But so far, the guidelines do not say that if you want to perform volumetric measurements, 3D is required. It still says that 2D or 3D examination of the volumetric examination. But 3D evaluation is especially the speckle tracking and the strain rate, which are the new modalities in the diagnosis of systolic and diastolic function of the left ventricle. There, the 3D examination is definitely better. But as I mentioned that they are still evolving and they are not yet come as guidelines and they have not yet replaced the 2D examination.
Sir, this insertion of TE probe, it can cause esophageal trauma, and
yes.
Can it lead to bacteremia? So suppose if the patient has a prosthetic valve, should we give them prophylactic antibiotic?
It can. If there is the surgeons and the patients, they do not like any trauma produced by the anesthesiologist. They do not come for getting anesthetized. They come for getting operated. So they do not like unless there is a class 1 indication for TE, then of course you are justified. But like I said, nowadays I do a lot of Ts in patients undergoing liver transplant surgery, and we have clearly defined that we will not insert the probe in grade 2, grade 3 varices and beyond. We will insert the probe only if they have been treated by the gastroenterologist by putting the stent, not the stents, but the what you call they put the ligatures on these varices. So if you have the varices, then definitely you have to be very careful. Maybe you should not use the T unless the T is definitely indicated. And upper airway trauma is the most common complication of the insertion of the TE probe. Therefore, you should not hesitate to use the laryngoscope while insertion, and also you must lubricate the probe very nicely. Use a lot of lignocaine jelly to insert your probe, and do not apply any undue if you force towards the while you are inserting the probe.
Should be gentle in your insertion.
Yes, you have to be very gentle.
So another question in the chat box is, how do you recognize anterior and posterior leaflet of the mitral valve?
Yeah, you have to know the anatomy. That's why, if you, this part of the presentation was only to familiarize you with the various images. Then you need to know the anatomy, and then you need to know the physiology and pathophysiology if you want to interpret the images. So the anterior mitral leaflet would be a structure that is anterior, and posterior leaflet would be posterior. So if you are examining a 5-chamber view, for example, and you know that the structure towards the aorta would be, aorta is anteriorly placed. So the leaflet that is closer to the aorta that you are seeing would be the anterior leaflet, and away from it would be the posterior leaflet. And in 4-chamber view, you have to know that the one on the right is the anterior leaflet, and one on your left will be the posterior leaflet. So you can always correlate the chambers. Well, if you are able to identify one chamber, this is the left atrium, then you can know that the valve adjacent that would be the mitral valve, and the chamber next to it would be the left ventricle. That is how you have to correlate, corroborate the anatomy. This is very useful and important if you see some abnormal chamber. So suddenly you start seeing some structure and you do not know what it is. Then you have to visualize some chamber or structure which you are able to identify. And from there on, you go on to identifying the structure that is in question or that is confusing.
Yeah, thank you very much, sir. Thank you for that discussion as well as the talk. Any other queries from the audience? I think sir is here, so he's the best person to answer any query on transducer vagal echocardiography. So if anybody has any query, I think they can unmute and can ask sir, because make use of this opportunity.
Never mind, I have shown my email ID and the phone number. So those of you who are feeling shy to ask any questions, feel free to write a mail to me or WhatsApp me or your question. I will ensure that I answer your questions and queries.
Thanks a lot, sir. Thanks a lot. So over to Binil.
Thank you, sir. Thank you, sir, for the excellent presentation. We acknowledge the presence of senior faculty members like Gurudat sir, Madhusudan Upadhyay sir, and Giri sir, please unmute and talk, sir.
Okay, I have unmuted. Dr. Agnihotri is there, past national president of ISA. I am seeing him for the first time in our this thing today. Dr. Pradhan.